process in drying, etc., we don't find fat stain to be positive. That is one disadvantage in this procedure. Of course, you can do it on a bone marrow imprint smear, confirm it with Sudan black or Sudan green. Then sometimes in a bone marrow assay, we may come across these spindle shaped or sometimes rounded cells, and some granules are coming out of them, and you find there is a pinkish flare around them. This pinkish flare around them, and similar pinkish flare you might have seen in a patient of, so far you find it. These are the basophils in the ventral sphere, and these are the masters in the bone marrow. So you can find masters of different shapes and sizes. Now this is from imprint smear from a particular case of mastocytosis, where the marrow has been replaced by these sheets of masters. And the masters introduce fibrosis, they also evoke a fibrotic response, so we don't get a good aspirate. When you do a reticulated stain, there is tremendous increase in reticulated stain, and this is a Freudian view which is positive, and this is a Ginza which is also showing these values. So what I am trying to show you are multiple special stains carried out on a defined biopsy, helping arriving at a diagnosis. And then the hemoglobin pigment, extensive increase in hemoglobin pigment you can find around these are globules of hemoglobin pigment. Smaller one in the case of aplastic anemia, and you can do a pulse stain. Now if you want to do a pulse stain on a defined biopsy, we don't use fixation in formic acid or PVC. Then we must do it in Xanthus fluid overnight. And if you do with the Xanthus fluid, the iron is not bleached. Iron is present as it is. But then there is slight modification for the pulse stain. We use 20% paper efficiency and 1% FKM, 1 in 3 parts, heat for 5 minutes at 80 degrees, and then we can get a good staining of iron, and you can assess the iron as per Klaus et al. From grade 1 to grade 2. Grade 1 2 is normal, grade 2 is increased iron flow, and that is how it looks like. If you are thick in Xanthus, you find the granules are present, and Klaus says don't count the extracellular granules. You should see only the granules in the intracellular, in the macrophage, and then we assess here you find increased iron, and here it is about near normal. Now talking about the pigment, a similar brown pigment you may come across in the bone marrow X-ray here, or same you find in the bone marrow defined biopsy. But what you find here is that this pigment has small globules of the same size, and if you see carefully at the bottom there is a gametocyte of falciparum. So each one globule belongs to one gametocyte of P falciparum, and it is not rare to come across cases of splenomegaly which you find the bone marrow contains lot of brown pigment, but in these globules. Similarly, in the defined biopsy, the appearance remains the same, small globules in the macrophage, and then some medium pigment which can be reached using the alcoholic citric acid. Now I go on to a particular case. This is a 50-year-old male who presented abdominal pain and also joint pain. His heart is weight loss, fever in the nose, painful knee and shoulder joint, gray pigmentation of the skin. Hemoglobin was 11. Transferrin saturation is pretty high, so is serum ferritin. Liver enzymes are disturbed, so they increase. Blood sugar is high, 140 milligrams, and that is what we found on the bone marrow defined biopsy. There was an increase in the iron. Going by the history, so clinicians usually don't write such a detailed history. You have to go and get the information from the patient. And we did suggested a liver biopsy, and what we find in a liver biopsy is that inside the liver cells there is pigment, and this pigment is nothing but iron. So the diagnosis is made hemochromatosis. Now my point of showing this slide was to differentiate it from cases of hemosiderosis. In hemosiderosis, what we find, the iron will be increased in the bone marrow, but in those cases we will find that the iron is present in the macrophages in the liver cell. Once the macrophages get overloaded with iron, only then the iron spills over into the liver cell. So this is hemosiderosis. The previous case was hemosiderosis. come across in the refined biopsy fungi. Now, histoplasma is not uncommon because nowadays we are getting many patients who are immunosuppressed because of steroid therapy, because of chemotherapy, various cases of lymphoma, and they are getting these infections. So, what you find here are the macrophages which have got these fungi and a clear space around them. Now, such macrophages are highly suggestive of a case of histoplasma. Of course, it needs to be differentiated from a case of Kala azar. Because in Kala azar, in a section the appearance may be similar. But what we find in Kala azar is that in the macrophages, the whole cytoplasm is just loaded with macrophages. Now, this is the imprint smear of a defined biopsy from some other case where we found large number of these histoplasma, and each histoplasma has to be differentiated from an antibody. Antibody, of course, you all know that there is kinetoplast and the body, but here we find there is a capsule around them. So you can always do a fast stain, you can do a super mechanical stain, and now this is a case. Here we find there is a ill-formed granuloma, but some rounded structures in between. Of course, this is nothing but typical appearance of different sizes of encapsulated fungus, and this is cryptococcus, and this is confirmed on silver methanomy stain, different sizes of this cryptococcus. Sometimes we find vague granulomas. Now we have made it a routine that wherever there is a necrosis, wherever there are histiocytes, wherever there are macrophages, suspicion of granuloma, we always do ESP and PS on silver methanomy to look for fungus and acid phosphatide. These are various vague macrophages seen on the acid section and refined biopsy, and we were not sure what we are looking at, so we did the fast, it turned out to be positive. To confirm cryptococcus, then we did the UC carbon stain. So this is a UC carbon stain which came out to be extensively positive, confirming the diagnosis of cryptococcus. And then similarly, we can do UC carbon in a case of metastatic carcinoma in the bone, where the patient had chemo for a long time and there was no growth anywhere, and what we found was that we did a UC carbon extensively positive, confirming that the patient has got mucus-producing adenocarcinoma. Later on, we found that the patient had a solid gastric malignancy, but it had already metastasized. Then I go to the last part, and that is the bony tissue. Now, after cell stroma in a defined biopsy, we should get some information out of the bony tissue as well. And that is what the bony tissue is. It is through a plastic embedding. And then we do a warm water stain. That is what we find. The calcified bone is black. The osteoid is not black. So this gives us an idea of the osteoid. And if you want to study the osteopathy, it is essential to study the osteoid. Now, we as a routine have been doing the bone marrow iron. So what we found was that even in cases, or all the cases where we are doing decalcification as a routine, what we found was the iron stain. You find this iron line is seen in almost all refined biopsies, and it comes same as with plastic embedding of the refined biopsy doing one for stain. So this is a very easy method to iron on a refined biopsy and then look for the osteoid seam. Now with this, the process has become simpler. We found a similar one reference where somebody has quoted that the osteoid seams could be visualized by doing an iron stain on a refined biopsy. And then we go on to immunohistochemistry. Because in various neoplastic diseases, we should be able to do immunohistochemistry. So we may do it in acute leukemias, chronic lymphoproliferative disorders. There have been talks by Professor Salah on the use of markers by using probe. But then most of us are not using probe, very few of us are using. But most of us are doing immunohistochemistry on histopathology section, on various malignancies. So the same can be applied to the defined biopsy. So I'll highlight some of these. Similarly, we can do diagnostic immunohistochemistry, And if you can do diagnostic, you can do prognostic also. In prognostic, you can study angiogenesis, proliferative index, apoptotic index, detecting translocation. Now this becomes, and then you can see another advantage of immunohistochemistry on a defined biopsy is you know which cell is state. If you do flow cytometer and if the morphology is not good, you may be gating the wrong cells and giving wrong results. Here you are examining what cells we are dealing with, whether it is a plasma cell, whether it is a lymphocyte, whether it is a leukemic cell. That advantage is present in immunohistochemistry. So in acute leukemia, whenever the bone marrow cells are not available in enough numbers in the bone marrow aspirate, we can do a bone marrow biopsy. Hypoplastic acute leukemia is one, where you don't get a good aspirate. Packed marrow, that is non-aspirable marrow. Packed marrow, you try to get it right hand. Acute leukemia with marrow fibrosis, you don't get anything on aspirate. Acute leukemia with marrow necrosis, you don't get anything. Leukemic leukemia, and of course the N7, which is associated with marrow fibrosis. These are some of the important conditions where we need to do immunohistochemistry to confirm the diagnosis. This is AML N7. You find there are blasts, there are megakaryocytes, there are pro-megakaryocytes, highly suspected of N7, and then you do a retinal stain. Retinal stain is increased as marked fibrosis in this, and then there are dysplastic megakaryocytes, and we do a CD61. Now, whether you do with a DAB or you do with APAP, that doesn't matter. This is APAP, and you can see the plant cells are positive with CD61. The pro-megakaryocytes and the megakaryocytes are also positive. So it becomes so easy to diagnose a case of AML. Then undifferentiated leukemia. You do a myeloperoxidase, FAST, NSC, they are negative. Clinical is always after you, whether it is AML or ALL, basic thing. And you do anti-MPU, it turns out to be positive. Those who don't have anti-MPU, you can do CD30, CD33, and it confirms the diagnosis of myeloid. And then various leukemia. In a defined biopsy, the picture is very clear cut, what we call as wide egg appearance or a wire mesh appearance. You find that around each nucleus there is a good amount of space. The nuclei are not superimposed upon each other, unlike various lymphoproliferative disorders, where you find that there is a cluster of cells. Where you don't find a cluster, but there is a clear gap around each cell, and that gives a wide egg appearance. Now you don't get good aspirate again because there is increased retinal throughout, and that does not allow good aspirate. And if you happen to have any of these good markers, 103, 123, or CD25, these cells turn out to be positive. You can differentiate it from peripheral leukemia variant, from SNPL, and of course you can also do a new antibody that is anti-drug positive antibody. And now we can do even pre-treatment and assess the prognosis following CDA. With CDA, it has got pretty good results with CDA, and you find that the number of leukemic cells has markedly diminished with one course of CDA. And then ZAP70. Now this is a new marker for diagnosis, for assessment of prognosis in ELS, where we classify as score 0, score 1, score 2. You do it on flow cytometry. Most of the centers are doing on flow cytometry, but it can be done even with immunohistochemistry, and the score can be made and you can assess the person. And then in a defined biopsy, you find that there is a polycellular environment and there is a fibrosis in between. Good amount of fibrosis is present. See carefully, there are some eosinophils and there are some cells which have got larger nucleus like this. And these are the cells which are suspicious, but you get a dry tap. And this is highly suggestive of a polycellular environment. Some mononuclear cells, it becomes Hodgkin. And if it is Hodgkin, and I must tell you one thing, that so far, we started reporting defined by 278, more than 52 years now. We have reported only 2 cases of Hodgkin positive on bone marrow aspirate. We don't get aspirate in Hodgkin. Almost always it is associated with fibrosis. And then confirm the diagnosis that this is the case of Hodgkin. Similarly, in cases of lymphoma, you know that this is a case of lymphoma, and you don't know the primary or the lymph nodes are not palpable. One can do the marker on this and confirm that it is T-cell NHL. Especially the T-cell NHL, we find that it almost always induces some element of myelofibrosis, of course, with the anaplastic morphology. Similarly, about melanine cell fibrosis, we find that the cells are CD1A positive on the increase. And then myeloma. Now, whenever there is an increase in plasma cells, we are worried whether we are dealing with myeloma or not, especially when it is 10 to 30%. Because if it is more than 30%, the diagnosis is made. So here we find that there are cells, and we as a routine in such cases do lambda and kappa chain. Since these are monoclonal, kappa chain is negative, lambda chain is positive. So we have been able to diagnose many cases of smoldering myeloma, many cases of anger on the basis of kappa and lambda. And this is what happens in the reactive plasma. In reactive plasma cells, we find the cells are both kappa positive as well as the cells are lambda positive because they are interlinked. So the diagnosis is made. And then going on to role of biopsy in various malignancies as a metastatic deposit. Besides this, gives us an idea of the hemopoietic reserve, and this is a case where we didn't find anything, but the patient has slight limp, and we did everything was normal except for the ESR, which was increased, and this is the cortex, subcortical marrow. We found few suspicious cells, and confirmed with cytokeratin, it was metastatic. We didn't know the primary, and then the tumor, wherever it was, it spread very rapidly. She had decided tumor diffusion expired about 3 months later. So the various conditions where we find bone marrow biopsy is positive on the breast, prostate, lung, kidney, adult, neuroblastoma in children, and germ cell. And as I told you that metastasis is almost always associated with marrow fibrosis. It may be little bit fibrosis or it may be extensive fibrosis. And where the cells are compressed, you can always do markers, cytokeratin, and confirm that we are dealing with it. Another case, 70 years old female with weakness and fatigue, and she had controlled diabetes, ESR was raised, serum protein showed increased globulin and reversal daily ratio, electrophoresis and band was raised, express lytic bone lesion. And this is what we found on the bone marrow X-ray. Since the picture was highly suggestive of myeloma, so we looked for plasma cells, and those were definitely increased. But one of my residents came and said the plasma cells are few, but she made a case of partial cells. There were a large number of these partial cells, and she was patient was pretty old. So whether it is just a simple case of multiple myeloma or not. Plasma cells were 9% of the marrow. There was increase in tissue size, and this is what the refined biopsy shows. The refined biopsy, there are more of these Gaucher-like cells, and there are few clusters where these Gaucher cells were surrounded by the myeloma cells. So we did CD68 positive for the Gaucher cells and T-kappa positive for these cells. So we had a case of multiple myeloma with pseudo-Gaucher cells. Now pseudo-Gaucher cells are seen in any condition wherever there is a rapid cell turnover. It may be leukemia, CMS, maybe ITP. Another case, the 50-year-old male patient presented low-grade fever, headache, muscle pain, weakness, anorexia, and skin rash. For 2 weeks, hemoglobin was 8 grams, low THC, basis function low, anemia was not responding to medicine. We carried out bone marrow aspirate and biopsy, and what we found was cells which were slightly spindle-shaped, oval nuclei turned out to be anti-tryptase positive, confirming the diagnosis of systemic mastocytosis is not very common. It's a rare disease of adults, and the bone marrow shows increased number of mast cells and metasomatic granules. And last part, I go on to osteopathic running out. I can continue for 5 minutes more. Now this is the base osteopathic are osteoporosis, osteomalacia, hyperparathyroidism, linear osteodystrophy, and Paget's disease. Now this is osteoporosis. Big case that I showed you is lack of bone. This is osteomalacia. Here there is too little bone. Here it is too much bone. There is too much bone, but then this too much bone is not calcified. There are thick osteoid seams. Less of calcium, more of osteoid. This is characteristic feature of osteomalacia. When you are doing a biopsy, you want to get some information out of it. And then osteopetrosis. This is from an infant. You find too much bone, hardly any marrow, and whatever is there is also showing fibrosis, and this child also has splenitis. So osteopetrosis. Osteomyelosclerosis, you find there is fibrosis of marrow, new bone formation is seen, and this is osteomyelosclerosis. And then we may find cases where you find different biopsies. These are two biopsies taken at different times. Marked osteoclastic proliferation, some fibrosis. Over a period of time, fibrosis increased, osteoblasts increased, and there was lysis of the bone. The bone was being eaten up by the osteoblast. So we had osteoclastic resorption, osteoblastic resorption, fibrosis, loose stroma, and still later what we found was that this patient had gone on to stage where you could find a typical picture of Paget's disease, where you find that marble floor appearance because of these various lines. There's irregular bone formation in Paget's. Stage 4, 55-year-old lady admitted with fracture neck of the femur, no lesions anywhere, fracture area only in the skull. But what we found was plasma desmal increased 7%. What was abnormal was serum urea and increased creatinine. So we had a patient of chronic renal failure. And what we find in chronic renal failure is osteoblastic proliferation. There is lysis of the bone, what you call as lateral resorption. There is a tunnel resorption of the bone by the osteoblast. And still more, you find further resorption takes place, and this eaten up bone gets replaced by the fibrous tissue. Multiple osteoblasts are lining the bone, eating away the bone. And then this is an appearance of hyperparathyroidism. There is extensive fibrosis, there is hemorrhage, large number of osteoclasts, and there is eating up of the bone. And this is something like a brown tumor which is come across in the case of hyperparathyroidism. And these are some of the manifestations of renal osteodystrophy. You will find parathyroid hyperplasia associated with it. You can assess by giving tetracyclines or minerals, but nowadays it is not being done. And now there are cytogenetic molecular studies which are being carried. So why are you not doing a bone marrow biopsy? Also, number one, needle availability. Now the needles are available. Cost of the needle is more, that is fine, but then if you get an all-string needle, it will last lifetime. More discomfort to the patient, but then in a setup where you are in government medical colleges, you don't bother about the money, neither does the patient because he doesn't have money. So you can diagnose many more cases on fine biopsy. The only thing is complex processing and protracted learning, because there are not many books available, but now slowly the books are coming up with bone marrow fine biopsy. Go ahead and do a defined biopsy, and from a defined biopsy, you can make the imprint meals, get some information out of them. You can do cytochemistry, immunocytochemistry. After decalcification, tissue processing, you can do as many special stains, immunohistochemical stain, and then study the bone marrow study. Finish it. Thank you.
Thank you. Dr. Interesting for this very exhaustive coverage of all conditions which can be diagnosed on bone marrow defined biopsy.